right, so now we're going to talk about Chapter 12. Chapter 12 is the primary assessment. So, the primary assessment is the basic assessment, and the whole purpose of the primary assessment is to find and treat life-threatening conditions. And there's thinking about the basic human pathophysiology, there's basically four things that are life-threatening. If you have an airway problem, a breathing problem, or a circulation problem, or anything that presents in an altered level of consciousness. So, life threats, although they can vary depending on the patient's condition, basically affect those things: airway, breathing, and circulation. Now, sometimes things appear life-threatening, but as you learn more, you'll be able to handle more and understand what actually can be treated on the scene and what cannot. So, what you consider life-threatening is going to start varying a little bit as you learn more. It also depends on how many EMTs are on the scene. Any other priorities that you might have as you assess the patient, or conditions of the scene safety may impact that also. So, the order of airway, breathing, circulation really depends on how the patient presents initially. If the patient has signs of life, basically if they have a pulse, airway, breathing, and circulation is the general order of assessment. But if the patient does not have a pulse, the order of assessment is CAB, and this is basically what you're learning in your CPR class. So when you take CPR, CAB is the order that you look for things and treat things, versus the person that has a pulse, it's ABC. And then once you have looked at that, you determine what immediate interventions might be needed and whether you have a little bit of time to do them there on the scene, or if you need to hurry and start moving toward a more definitive treatment at the hospital. So, as you start to assess in your primary assessment, if there's any vomit in the airway that can enter into the lungs, this can be very serious and even fatal. Airway means that tube that brings air in from outside environment down to the lungs. If you have vomit in it, it's going to block that from happening. If there's a life-threatening bleed, so an exsanguating bleed, needs to be stopped immediately. That needs to be treated before they're moved. These are things that you can do on the scene. You can suction a patient, you can stop bleeding, and you can start breathing the patient and even do CPR for circulation. And those are absolutely vital for life to happen. You can't wait to move that patient to the ambulance to do that. So, if immediate interventions such as bleeding control or CPR are not required, then you can shift to and still important, but maybe a less urgent mode in which you start giving oxygen or evaluate the patient for shock from there. But the purpose of the primary assessment is to find and treat life-threatening injuries and determine how quickly you need to move the patient, or if you need to do some major critical interventions. These are the steps to your primary assessment. Step 1, form a general impression. Step 2 is to assess their mental status, or step 3, which is assess the airway, 4, assess breathing, 5, assess circulation, and the 5th thing that you're doing is determining the priority of the patient. Is it time to load them and move quickly? Or can you stay and do some further interventions? Do you have a little bit of time? So this is the general order. If you think about it, when you've learned in CPR, you look, listen, and feel. You say, hey, are you okay? That's assessing mental status. You open the airway, check for breathing, check a pulse. So it's the same way in this primary assessment. So a general impression. To form a general impression, you have to kind of look at the environment the patient's in. You have to find out, what is their chief complaint? What are they saying is wrong with them? What were you called for? Sometimes it varies once you get there. They may say that that they're having chest pain, but when you get there, they just feel a little sick. But another big indicator of how critical they are is their appearance. As you look at them from across the room, how do they appear to you? Do they look like they're sick? Do they look fairly healthy and like maybe there's nothing going on? Your general impression helps to determine the patient's severity. Sometimes if they look sick, or you got that gut instinct, and generally that's just from experience and practice and looking in people, you can look at them and say, oh, they definitely look sick. And then this also will set the priorities for your care and for your transport of the patient. So, the look test. You want to feel from the environmental observations as well as the first look at the patient. So, do they have used Kleenex and a trash can next to them, and they're all snuggled up in a recliner and they look like they haven't moved from that recliner for several days? That's an indication of somebody who's been sick for a few days. Or do you walk in and immediately you smell, and the house smells like they've had diarrhea for a while? The smell of blood will sometimes be in the air. The environment. Are there pill bottles around? Is it unusually quiet? Those are things that you notice, and the more you get out and go to emergencies, the more you'll get a feel for what is going on here and what seems odd. So, here's a general impression. Look at this little girl. Looks to me like she might have fallen down. Maybe she was trying to rollerblade with her new rollerblades. Form a general impression, and that includes your immediate assessment of the environment and then the patient's chief complaint and how do they appear. Well, she looks to me like she's alert, seems fairly oriented, maybe a little bit emotional, but it doesn't look like she's been knocked out in any way. So your general impression is going to help you identify patients who may be critical. Patients who appear lifeless will probably need resuscitation, beginning with CPR compressions, and to get an AED just as soon as possible, because that's going to be the definitive fix for them. If they've got an altered mental status, or if they appear unusually anxious, or if they appear pale and sweaty, might be an indication that they might be a little bit more critical than the normal patient. And then identify patients who have been critical. Obvious trauma to the head, chest, abdomen, or pelvis. Specific positions that they're sitting in will indicate distress. There's something called the tripod position. If they're having difficulty breathing, they lean forward and put their hands on their knees and try to hold their chest up to breathe in as best as they can. There's another thing called Levine's sign, and if you look on page 290, up at the top, the picture, there's a guy up there that is an indication of Levine's sign. If they grab a fist and clutch it to their chest, that's an indication of chest pain. Patient's description of why EMS was called is the chief complaint. Now, A lot of times you'll get a different description after you get there. So ask them once you get there what seems to be going on today, what you're dispatched for, and what you get there. Sometimes match, sometimes they don't. Might be specific description. I have abdominal pain, or it could be very vague. I'm not feeling good. And some people will say that they haven't been feeling good for several days or weeks, or even, well, I haven't been feeling good for the last month. In that case, you want to know what is different, what has changed that made you call an ambulance today. And in your chief complaint, as you form an impression of the patient, you want to look their age, their sex, what position they're sitting in, and then listen. Is there any moaning, snoring, or gurgling respirations? What does it smell like in the environment? Are there hazardous fumes? Is there urine smell, feces, vomit, or decay? AVPU. This is a mnemonic that needs to be memorized. A stands for alert, V stands for verbal, P stands for painful, U stands for unresponsive. If they're alert and they're oriented, they know what's going on. They can be alert, but not oriented. Maybe slightly confused. Maybe they don't remember where they're at or the time of day it is. If they're verbal, that means when you talk to them, they will respond to your verbal stimulation. And if they don't respond to you talking to them, do they respond to you doing something painful, such as a sternal rub or pinching them? Will they respond to that? That's responding to pain. And if they respond to none of that, then they're unresponsive. So once again, if they're alert, they'll look at you and be alert and automatically know that you're in their environment. That doesn't mean they're oriented though, so you want to know if they're alert. But the other thing you want to know is if they're oriented. If they don't respond to you automatically, then you talk to them and see if they respond to you verbally. By you talking to them, do they move or look at you? If they don't respond to that, do they respond to you doing something painful? And if they don't do that, they'll be completely unresponsive. The order of the primary assessment will vary depending on the patient's condition. Okay, airway, breathing, circulation for a patient that has a pulse. If you find any problems in these areas, you need to correct those. So if they're having a breathing problem, you need to ventilate them, breathe for them. If they're bleeding, you need to fix that before you move on to the next step. Then you would also gather information that will help you later in your assessment. So here's a patient. As they walk in, you're going to look for signs of life, including whether they're moving or not. Scan the chest for signs of breathing, and if no signs of life, such as breathing or only gasping breathing, are found, then check a pulse, just like you've learned in CPR. Airway. If a patient is alert and talking clearly or crying loudly, then the airway is open. If the airway is not open or is endangered, take measures to open it. They might have vomit in their throat. They might have their head tilted too far back or too far forward where their airway is blocked. Remember, when we talk about airway, is the tube open that's going to let outside air down into the lungs. That is an airway. That's a patent airway. Breathing. Breathing is the actual physical air going in and out of the lungs. So you might have to do that if they can't do that on their own. If there's respiratory arrest with a pulse, well, all you have to do is ventilate them with a bag valve mask. If they're not breathing or they're not alert and they're not breathing adequately, their chest rise isn't enough, or they're breathing too fast or too slow, you have to assist them with a bag valve mask. If Even if they're a little bit alert and they're not breathing adequately, you might have to assist their ventilations. And if they're having signs of respiratory distress or hypoxia, which is low oxygen, you might have to assist that air going in and out to make sure that it's adequate. Circulation. With circulation, they usually have warm pink dry skin. If you're in shock, there will be pale, cool, or moist and clammy skin. So you want to assess that. Check a pulse. You check a radial pulse in somebody that is alert, and you check a carotid pulse in somebody that is unresponsive. And check a pulse for no longer than 10 seconds. There's 3 results that you're going to get when you assess a pulse. First of all, does it feel normal? Kind of an adequate rate. Between 60 and 100 is an adequate rate. And if it feels a little bit slower than that, that might not be a good circulation. Or if it's faster than that, then they might be in shock and their body is trying to compensate. And the circulation check, when you're checking for circulation, you're also looking for and controlling any severe bleeding. So, to be stable, a patient needs to have vital signs that are in the normal range or just slightly abnormal, or a threat to the airway, breathing, or circulation, either actual or imminent, rules out stable. If there's no pulse, begin CPR compressions while the defibrillator's getting ready. And there are many times when it is not crystal clear what a patient's problem is, so there will be many possible diagnoses, some more serious than others. And you know what? A patient's priority can change. Originally, they might have been a little more stable, and then later on, you determine that maybe they aren't doing as good as you thought. Initiate priority transport if a life-threatening problem cannot be controlled or threatens to recur, and then continue assessment and care en route. So, why do you need to continue to reevaluate the primary assessment? Of course, it keeps changing over time, and you want to make sure that you don't miss any changes if it does. So how might normal findings in a primary assessment differ for a child compared to an adult? Kids are more susceptible to respiratory problems, and so pay close attention to their breathing. Sometimes they're harder to see the subtle changes because their bodies compensate so well. Our chapter review. The primary assessment is a systematic approach, and it helps you to quickly find and treat immediate threats to life. The general impression, although it's subjective, can provide extremely useful information regarding urgency of the patient's condition. The determination of mental status follows the AVPU approach: alert, verbal, painful, unresponsive. And then evaluate airway, breathing, and circulation quickly but thoroughly. That'll reveal immediate threats to life that must be treated before further assessment. Your approach to a patient will vary depending on how he presents. The American Heart Association recommends a CAB approach for patients who appear lifeless and apparently are not breathing or have only agonal respirations. Do you remember what agonal is? Remember your CPR training, and that is not adequate breathing. This begins with a pulse check and chest compressions if there's no pulse. If your patient shows signs of life, they're moving, they're moaning, they're talking, and they're breathing, you will take a traditional ABC approach. Remember that the mnemonic ABC is a guide to interventions that can be taken. They are life-threatening problems if you find a problem with them. You're going to choose your interventions based on the patient's immediate needs. They may be done in any order that fits the patient's needs. The patient's priority describes how urgent the patient's need to be transported is and how to conduct the rest of your assessment. So remember, determine if a patient is responsive or unresponsive, whether the patient's an adult, child, or infant. Rapidly identify the need for immediate airway intervention. Determine if the patient's condition is stable enough to allow further assessment and treatment at the scene. What factors will you take into account in forming a general impression of the patient? The environment, the age of the patient, what their chief complaint is. How should you assess the patient's mental status with regard to the AVPU level of responsiveness? Well, first of all, do they look at you when you first approach? If not, do they respond to your voice? If not that, do they respond to anything painful? If not, they're completely unresponsive. How should you assess airway, breathing, and circulation during the primary assessment? Look, listen, and feel. And what is meant by the term priority decision? That means how quickly do you need to get them loaded and moved towards the hospital? What interventions need to be done on the scene? If they've got an airway, breathing, circulation problem, then you should probably fix those before you move them. A middle-aged male is lying on the street after being hit by a car. He appears unresponsive as you approach. You notice that he is bleeding from a laceration on his forearm and making gurgling sounds from his airway. Does he have a life-threatening condition? And how quickly does it need to be fixed? First of all, his mental status is unresponsive. That makes it life-threatening. And second of all, he's got gurgling sounds in his airway. He has an airway problem. He needs to be suctioned quickly. That vomit doesn't need to be down in his airway. That'll block the oxygen getting to the alveoli where it needs to be exchanged. If you are alone, what factors do you consider in deciding what to do first? Well, what's your priority? Airway is a specific priority. So, opening his airway, using the jaw thrust, suction his airway, and try to fix that intervention. And also, hopefully you've got help coming, so get your resources on their way.